everyone. Thanks for joining us. Happy Pride Month. It is June 2021, and at CGI, we celebrate Pride Month by highlighting health challenges faced by the LGBTQ population and by focusing on evidence-based solutions and innovations to work towards equity in access and quality of care for all populations. So in a couple of facts about today's discussion, doing some research into this area, in 2011, the Institute of Medicine issued a report that outlined a research agenda targeting several areas that could affect how the healthcare system approaches LGBTQ health, including looking more and capturing more data on demographics, social influences, disparities, inequities, and interventions that include increasing access to care and addressing physical or mental health conditions, as well as transgender specific needs, which is a huge, huge area of healthcare that we need improvements in. The report also recommended inclusion of the LGBTQ community in national health surveys and emphasized a need for scientific rigor and a respectful environment when gathering data. So after that 2011 report, fast forward to 2015, the American College of Physicians published a position paper with recommendations to address health disparities for the LGBTQ population. Then fast forward to June of 2020, when we had a Trump administration rule that would remove non-discrimination protections for LGBTQ populations when it comes to healthcare and health insurance. However, in May 2021, after the election, the Biden administration reversed that policy and ensured protection under the law for trans individuals against sex and gender discrimination in healthcare and at work. So right now, the Health and Human Services Office for Civil Rights, the OCR, will again investigate complaints of sex discrimination on the basis of sexual orientation and gender identity, which is a big win for the population and for all of us as healthcare professionals. Hospitals, clinics, and other medical providers can face government sanctions for violations of the law. So one additional pretty big win is at the Health and Human Services. Biden's term has seen the Senate confirmation of Dr. Rachel Levine as the Assistant Secretary for Health. This is a senior position that involves oversight of public health initiatives, including HIV and AIDS, women's health, and minority health, and other areas including research protections. Levine is formerly Pennsylvania's top health official and is the first openly transgender person to be confirmed by the Senate. So in my opinion and in the CGI model of care, we always want to make sure that individuals are able to advocate for the health that they know they need as a population. So it's great to have such a strong advocate in that role. Today, our podcast discussion will focus on the progress that has been made since that 2011 report was published by the IOM, as well as the ongoing challenges in pursuing health equity for the population in 2021. So to introduce our wonderful guest, Michael Garrett is a principal at Mercer, where he leads consulting engagements with large plan sponsors regarding their health benefit plans and works with clients in developing and implementing new care delivery models, such as ACOs. His education includes a master's degree from the University of Idaho in clinical psychology and a bachelor's degree in psychology from Gonzaga University. He is a certified case manager, certified vocational evaluator, a board certified patient advocate, and a nationally certified psychologist. Michael has served in operational management, business development, product development, consulting, and strategic planning roles. So we're just really excited to have Michael with us today to talk a little bit about this particular population. And one additional fact, Michael has authored and/or edited 6 case or care management books and is the author of numerous journal articles in the field. In fact, he is frequently invited to speak at national conferences on many topics. So welcome, Michael. Thanks so much for being here.
Thank you, Dr. English. I'm glad to be here. And your talk actually reminded me of 2 other things I want to just point out that are relevant to the history. So actually going back even further to 2001, the Institute of Medicine issued their report called Crossing the Quality Chasm, where they identified the 6 aims of a high-functioning, high-quality healthcare system: safe, timely, effective, efficient, equitable, and patient-centered. And when I talk about this, I tell people, you know, I've seen a lot of progress in 5 of the 6, but health equity seems to be just coming to the forefront with health systems and health plans. And the other development was in actually June 15th, 2020, so about a year ago, the Supreme Court of the US, SCOTUS, issued a decision that indicated that sexual orientation and gender identity are considered to be included in Title VII of the Civil Rights Act of 1964, prohibiting discrimination in the workplace on account of sex. So although that was not specifically around health benefits, the concern is that since many people get their benefits from an employer, that could provide some additional coverage or protection for the LGBTQ community in light of that SCOTUS decision. And of course, we also have the Mental Health Parity Act of 2010 that covered psychiatric conditions on an equal basis. And because gender dysphoria currently is considered to be a psychiatric diagnosis in the current Diagnostic and Statistical Manual, that it's covered, gender dysphoria is, which is a diagnosis transgender individuals have. So those are a couple of other things I thought of as you were speaking that I think were
great points, Michael. Yeah, and you know, as you were talking too, I was thinking some of the statistics that I've read recently related to employment and, you know, having primary healthcare benefits through employment is that transgender individuals, particularly minority transgendered individuals, end up having a higher rate of unemployment, often due to being transgender. Mm-hmm. And so, you know, if access to work and, you know, continued employment is an issue, then of course, access to healthcare coverage is going to be an ongoing issue. So that's, you know, another disparity that I don't think a lot of people really think about that issue of, you know, if you're unemployed, you also run a much higher risk of not being able to access health benefits.
Sure. And a couple of other things I think to round out, like, who did Dr. English get here? So I've been involved in a variety of initiatives around diversity, equity, inclusion. So where I work at Mercer, I'm the North American co-chair of our Pride Business Resource Group. Mm-hmm. I'm also involved in some other business resource groups as well. I was appointed a couple of years ago to the City of Seattle LGBTQ Commission, right. Which is one of 5 civil rights commissions providing advice to the mayor, city council, and staff. I'm no longer on the commission, but served for a couple of years. Mm-hmm. And I also am an openly gay man, and I actually have a transgender son. Mm-hmm. So very immersed in this area on a personal basis. And I call myself an aging activist, you know, so.
Don't we all?
and actually within the last year, because of what's gone on, have done a lot of work around diversity, equity, inclusion, and health and benefits, broadly speaking, not just specific to LGBTQ. But for the last 4 years in my day job, I've also been involved in conducting reviews of clinical coverage policies for gender affirmation treatment to determine if they are in alignment with internationally recognized clinical guidelines for the treatment of individuals with that have been diagnosed with gender dysphoria.
Yeah, I'm curious about that. So in terms of kind of an environmental scan, what's the landscape look like at this time for coverage and the quality of care?
So very interesting you asked that. I keep thinking that work, which we've been doing for 8 years at Mercer, is going to go away, and it just keeps coming back. And so I think there's progress. I point out to our clients and prospects and my colleagues, you know, not to fearmonger, but just from a regulatory compliance issue, as I mentioned, we have the mental health parity and we have the SCOTUS decision of June of 2020 that should prompt them to have coverage. I would say most employers have some kind of coverage with for gender dysphoria. Most have so-called bottom surgery, so genital surgery. Some have top surgery. Hormones are usually covered. Behavioral health's covered. The challenge is the reconstructive and complementary procedures. So things like voice training, electrolysis, facial feminization, chest masculinization, and so forth are typically not covered. And so it's a journey, I will say, to enlighten employers, and also, frankly, at the health plans, to have them update clinical coverage policies to include, because sometimes the complementary and reconstructive procedures can be more powerful and impactful to transgender individuals than surgical procedures. Right. In fact, from a 2015 survey that was done in this country, 0.6% of the population identified as transgender, and only 25% that said they'd had any surgical procedure in their lifetime. About half did hormones, about half did behavioral health. So your students in behavioral health, you may very well encounter patients. But I find, frankly, the health professionals get very focused on surgical procedures. And I would just suggest to you, don't focus on surgical procedures. Remember to give that whole person approach, and it's about living in their true identity.
Yeah. Can you say a little bit more about that? Because I because of who I am and because of my own passion in this area, I do a lot of reading and research and continuing education. But I'm not sure that people understand that when you're looking or working with an individual who's transgender, that the first question shouldn't be, so have you had a surgery or are you going to get a surgery? And why is that a tense area, kind of a bee's nest to step in for a person who doesn't know any better?
Sure. Yeah, I think first it's making sure you understand how they identify themselves in terms of pronoun, name, regardless of what you may find in any electronic health records. Listen to the patient about their name, their gender, who they define as family, and so forth. Let me pull up a quick slide if I could.
Yes, please.
And show you, there's actually, we think of transition kind of, that is surgical procedures. And the way I think about transitions as others do is social, legal, and medical. And so social is letting other people know your identified gender. It may involve name change, it may not. Just that gender expression piece, that's a big part of it. There's the legal part, which can be actually much more straightforward around changing your name and your gender and so forth. And then medical, of course. And then again, with medical, there's behavioral, hormones, et cetera, et cetera. And there's also non-medical ways of expressing your gender. So listen to what the patient says and mimic what the patient has to say, as opposed to what you might find in an electronic health record.
Yeah, that's a really great suggestion. And I like the word mimic. Because it's easy to remember. And, so if an individual, has, I think for a lot of people, as medical professionals tend to go by what's in the chart. And so if, sex assigned at birth is the way that it's been charted, then I've noticed that professionals have a hard time with pronouns.
Yep.
So
I wonder if I could back up and kind of make sure that everyone's grounded in when we're talking about.
That's a great idea.
Yeah, no, this is great dialogue. Can you see that?
Yep, sure can.
So this is a really great way to understand when we're talking about sexual orientation and gender identity, and the acronym that is SOGI, sexual orientation, gender identity. It's just really important, maybe obvious to people, but I think this is actually a really easy way and a non-threatening way to kind of understand this. So there's gender identity, which you see there, the little going to the brain is how I envision myself. Whether it's male, female, gender non-binary. I know that some people, for example, when I've been introduced to them, it's like, I don't want to use a pronoun. You just call me by my name. Right. So they don't want to be anywhere on, that continuum. One of the things that I would say you could advocate for in your own healthcare system is allowing people to identify as gender non-binary, for example, because to what's called misgender someone by the wrong gender can be very harmful, actually has physical or psychological and physical impact. Then there's gender expression. And gender expression is very much rooted in whatever culture you're in. And so I talk about, if we were 300 years ago, Dr. English, I'd be wearing like a powdered wig and blue breeches. If I was a woman in China in late 19th century, I would have foot binding. That would be considered the ultimate feminine. If you were in a certain tribe in Africa, the number of rings around your neck would be an indication of your femininity. So just be clear, the gender expression is very much rooted in the culture and the time that you live in. Gender expression also does not tell you someone's identity and does not tell you your sexual orientation. We tend to leap to those conclusions because, as human beings, we want to categorize people. So that is a common mistake that people can make by start gendering someone based on their observation. So I would just recommend that you don't do that. And a way to do that is when you introduce yourself, when you're first meeting with a patient, is identify, my name is Michael Garrett. I'm your nurse or your counselor or whatever. I use he, him, his pronouns. That signals to the other person that it's okay for them to reveal or not reveal their pronoun. It's up to them.
Mm-hmm.
Then there's the idea of attraction or sexual orientation. And I would also say, if you come away with anything from this talk, that everything's on a spectrum. Kinsey in the mid 20th century identified that sexual orientation is on a spectrum. He used, I think, a 0 to 7 scale or 1 to 7 scale, and from a completely heterosexual to completely gay. So, and then there's also, of course, the people who are asexual that do not have any romantic or sexual attraction as well. And then last but not least is the biological sex. And so here it's important to point out, although very rare, there are people who may be intersex. The other terms that are used are disorders of sexual development or differences in sexual development. People who are older like myself, the term that was used was hermaphrodite. We don't use that term anymore. Intersex is the term that's used. And so these are people who have both either primary or secondary characteristics of both male and female. They may be physically obvious, they may not be. It may be internal organs, and the person actually may not be aware of that until later in life. And the other suggestion I would make here is you may be called in on a consultation with parents who have just given birth to a baby who is intersex. Mm-hmm. And the strong recommendation from different medical societies and associations is, unless there is a physical reason to do any kind of genital surgical procedures, they recommend not doing anything. Otherwise, it's gender traumatizing for someone then to realize later on in life that they actually had sexual characteristics of both male and female. So that's kind of just making sure we understand identity is who I think of, regardless of my primary, secondary sex characteristics. Attraction is who I'm attracted to, again, regardless of what organs I have or don't have. Gender expression is how I express myself, very rooted in country, time, space, as defined by society, and then the biological sex in terms of the sexual organs and secondary characteristics that one possesses. So I think it's really important to make sure we all understand what we're talking about. So when we talk about the LGBTQ plus, lesbian, gay, bisexual, transgender, queer, and sometimes we add intersex and asexual.
Mm-hmm.
Sometimes
for folks who didn't know that it can sometimes look like LGBTQTIA.
Yeah.
Did I say that correctly? Or did I add an extra T? I
think you added an extra T. That's okay. And another kind of, I think younger people in particular, it's more difficult for someone like me where I'm at in my life, use the word queer, and then that's just very all-encompassing. Sometimes people use the phrase sexual minority or gender minority to kind of come up with an all-encompassing. So really the LGBTQIA is when we're talking about is very different domains that we're talking about, but we kind of all get lumped together. Sometimes we call ourselves sexual outlaws or gender outlaws because we don't conform to societal norms around attraction or identity. So I just want to make sure that this is a really kind of simple way of thinking about it in terms of the LGBTQ community.
I like that a lot. And do you mind sharing that visual with me so that I can link it for folks who are listening to the podcast rather than watching?
Sure.
Okay, great. Thank you so much. Yeah, it's very helpful because, even as a professional, I make every attempt anytime I see a webinar that I can attend, I try to go. And I'm, very much passionate about advocacy and improvement for this population, but I still get it wrong. And, I think one of the things that a lot of people fear is it's kind of the you avoid the thing that you're afraid or you lack confidence in talking about. And I know, for me, one of the things is just to be ready to own anything that I mess up.
Sure.
And, to make sure, again, like you said, is that you're asking the person for their way of being referred to, named, and, discussed, and just like you would any other preference, and just like you would establish a rapport and consent,
Yep.
in healthcare delivery with any other patient. So there may be some additional questions. I think sometimes physicians, especially those who are, a little bit older and maybe have or feel that they have less time to attend, continuing education in general, feel like, let me just push that aside to younger professionals. And I don't like that approach personally, but I can understand it,
Yep.
because it is hard. So I really appreciate it when we can talk about this and, provide some definitions and give a framework for opening the door, maybe even just cracking it open a little bit further to open those conversations.
Sure. And I would just make sure that we don't use the word preference. Preference sounds like it's a choice, not to be critical here, but I just want to make sure that we talk about the correct pronoun, the correct gender, or the identified, or what have you. I also wanted to there's another side I wanted to share, Dr. English, too, that I think of this whole conversation is around what we're now calling diversity, equity, and inclusion, right? So historically, and again, where I'm grounded is working, for large corporations, and I've worked for nonprofits as well. Diversity has historically been seen as a compliance issue, like, how many Black employees do we have? How many women do we have in management, and so forth? It's really not incorporating and infusing the concept of equity and inclusion in a culture. And so, fortunately, employers now are really realizing like they have to go beyond diversity. Diversity, we talk about diversity is a fact. Like we have, as I mentioned, X number of percent of this or that or the other. Equity is a choice. Equity is a choice that you make at a healthcare organization. Equity is a choice that an employer does when they design their benefits to be as inclusive as possible. And we think about diversity, equity, inclusion from a variety of domains. So equity is a choice, inclusion is an act. And what it tries to lead to is a sense of belongingness. Another way I talk about the analogy, and many people have said this, diversity is like inviting someone to the party who's not like you. Inclusion is asking someone to dance at the party who's not like you. And also inclusiveness is making sure that people are able to get to the dance floor. So for people who may have different kinds of ability statuses. The other point that I will make here is, although I know we're talking, it's Pride Month and Happy Pride Month and LGBTQ, people are intersectional. And Dr. Kimberly Crenshaw coined that term years ago. And basically what it's saying is we're all of our aspects of ourselves, our sexual orientation, our gender identity, our race, our ethnicity, our ability status. And we oversimplify if we try to boil people down to just their sexual orientation or gender identity, and they may be coming to you having nothing to do with their sexual orientation and gender identity. And so just remembering that in terms of keeping that whole person approach in place, there are particular healthcare needs and concerns that the LGBTQ population has, but they can be a part of lots of different communities, and they may actually identify, if I have hearing loss, I may much more identify with the deaf community than I do the LGBTQ community. Right. So we just try to slot, it's human nature, right? To understand things. We try to slot people in like, oh, they're this or that. So it means X, Y, Z. And trying to have that sense of getting the whole picture of the patient, which I'm sure your university supports. And the idea is that the end game is that sense of belonging. Now, in the context of healthcare, it would be the member experience, right? And many organizations do different member experiences or satisfaction scores or whatever. That's what we're trying to lead to, and really so that everyone who walks through the door is experiencing equitable access and treatment and outcome in order to avoid health disparities, which can be defined as unjust and inequitable and unnecessary variances in access to healthcare or the experience of healthcare and the clinical outcomes of healthcare. So I just want to make sure we're grounded in kind of these concepts of diversity, equity, and inclusion. When we're talking about and I like the word underserved populations when we're talking about healthcare. Sometimes people say underrepresented or marginalized. I don't think there's any right or wrong answer, but I think underserved is a good word we can use in the context of healthcare.
Yeah, I think that's a great word to use just in terms of certainly of access as well as equity, just being under the bar.
Yep.
Where we want to be. Yeah. Thank you for that too. And for those of you listening, I'll share in the links the slides that Michael's been sharing. So I would like to know a little bit, from your perspective on, for my students at Cummings Graduate Institute in the Doctor of Behavioral Health program, many are learning how to be a catalyst in a healthcare setting. So many of them are already in leadership positions. For example, the Director of Behavioral Health is a pretty common position for a student in our program. Some of them are also, leaders and managers in other kinds of settings. It could be outpatient, it could be partial hospitalization, it could be inpatient, it could be, part of a large emergency department team. So really, really diverse and also diverse geographically. Many are in rural areas with, fewer resources available, whereas some are working in urban areas with more resources available to them in terms of training or, support or maybe even funding to make improvements. So from your perspective, what are a couple of key concepts or key areas of focus where people can begin just to really kind of level set for their own organization in terms of how are we doing for our population of patients that happens to identify with the LGBTQ population?
Mm-hmm. So I would talk about that at several levels. Mm-hmm. One is at the policy level. Mm-hmm. So, and I don't mean just ensuring that your anti-discrimination includes sexual orientation and gender identity. I mean things like allowing people to identify as gender non-binary, allowing, including domestic partners, even though there's marriage equality, some people, particularly in certain regions of the country, don't want to be legally married because it becomes public information. Having gender neutral restrooms available to individuals. So those are kind of at the organizational level. And another one are policies. At the organizational level, that's another level, which is having senior leaders who are open members of the LGBTQ community, having an LGBTQ employee resource group or business resource group, or if you have like just a single diversity council, ensure that representation comes from all underserved populations, including but not limited to LGBTQ. Use of pronouns and signatures, and making that optional, not requiring people. As I mentioned, there are some individuals that don't want any pronouns used. Making it easy for someone at your organization to change their gender if they're going through a transition process. So those are some organizational kinds of things, and ensuring that.
Let me ask you really quickly about the use of pronouns. So I know right now there's a lot of discussion because there are some who feel like they're afraid that if they start using pronouns on email signatures or, in your Zoom, name, mm-hmm. that it is, just trying to jump on the bandwagon or be perceived as affirming. Mm-hmm. And then there are other people who are, advocates. And so they're out there and they would have done it, 100 years ago if it had been an option for them. And it's just occurring to us to do that now. And so what's your recommendation and how do you kind of talk through that with organizations to help them make the right decision for them?
Yeah. A couple things. One is making it optional, never requiring people. So making sure you frame it like if it's a verbal or, in-person meeting, like if you're comfortable sharing your pronoun, please do so. Mm-hmm. I routinely do my pronoun. Most people don't, and that's fine. In terms of people's sincerity, it's also like people hanging up Black Lives Matter banners, and is that really true? none of us can judge that. I think that the feedback, I thought what you're going to say is that people feel like, oh, is this forcing people to out themselves that they're gender non-binary?
That's a good question too. I hadn't really thought about it.
That's what I thought you were going to say. And I think that you've got to frame it as voluntary.
Yeah.
It's recommended. I think the key is explaining why it's important. And I kind of touched on when I said, if you start guessing someone's gender based on their gender expression and you guess wrong, that's very hard on individuals. I mean, it does have psychological and physiological impact on individuals. So that's why I make it a safe space. If someone wants to reveal whether it's they, them, or maybe they present more masculine, but they are she, her, then they can do that. So they're not misgendered. So that's the intent.
Yeah, thank you for that.
Sure. Let's see, I lost my train of thought. Oh, so then in terms of another level would be, does your electronic health record have gender non-binary? Does your EHR have room for identifying a spouse or family of choice as opposed to a family of origin? Those are the kinds of things. Having training on LGBTQ healthcare needs, for example, and give people continuing education credits. That'll get them to go, right? And so those are the kinds of things that you can do. So educating yourselves, when I give talks to healthcare professionals, nurses, social workers, counselors, and so forth, they're like, wow, I just had my first transgender patient, for example, and I didn't know what to say or do. And I wish I would have had this talk, prior. There's also some things that you can do, again, because I come at it from a health and benefits perspective, and I do this all the time, of looking at benefits from in healthcare coverage from the lens of the LGBTQ population. So, do you cover PrEP for preventing HIV infection?
Right.
Do your policies cover fertility for same-sex couples and single people? So common phenomena that occurs, Dr. English, is that, for example, fertility benefits, to access it, you have to have a diagnosis of infertility. Well, you've just eliminated single people and you've eliminated same-sex couples. And I think that that's actually kind of inadvertent. I think that no one really kind of thought through it maybe when they did that. And so, like, stepping back and I've even been asked to take a look at like a benefit booklet, like, hey, take a look at this to see from an LGBTQ lens, and things like men should get prostate exams between the ages of, I don't know, 40 and 50. It's like, well, why are we saying men? Why don't we just say for those individuals who have prostates, they need to have, do you see what I mean? So taking that gender out of it, because it's not necessary. And then I think also with folks on the call, that with a healthcare lens, another phenomenon that happens, for example, let's say you have an individual who's a transgender male, has had no surgical procedures, has legally changed everything over, it's in everyone's systems and so forth. Well, then you can miss, like, oh, they need a pap smear.
Right.
You know what I mean? Or they need a mammography.
Right.
Because
and that comes across in the statistics, and of course I'm in women's health. And so, for transgender men, that is a problem. There's a much lower rate of those procedures for that group. And so we want to make sure that we're reaching them. However, they may not be coming into women's health. They might be going instead to a primary care that, may not be as trained or comfortable.
Right. And then the same for a transgender woman who has no surgical procedures. They still need prostate exams or potentially testicular exams when they're younger. So anyway, those are the kinds of things that can be very, you can overlook. Or, if they do have those kind of preventive screenings and they get submitted to the insurance carrier and they deny because their claim system auto-deny,
based on, sex assigned at birth.
Right. So, you're listed as male, but you had a hysterectomy,
I think it's
deny. So when I talk to my colleagues at health plans, it's like, have a dedicated team that is trained their claims people and the clinicians that really understand the needs. And that may be true. That's another option to get back to your question, what can you do in your own organization? Some healthcare organizations have now what's being called gender health clinics. So it's not transgender, it's gender health clinics.
Yep.
And so they have a dedicated team of not just clinicians, but also staff. Because here's the deal. When you walk into brick and mortar, I'm talking about, and someone comes in and the perception is that they're male, but they're dressed in female clothing. And if you have a negative reaction from the receptionist, the medical assistant, whomever, like that person ain't coming back. Yeah. So it's not just the licensed clinicians that need the training, it's all staff, housekeeping, dietitian, dietary, all of the staff need to be trained. And I think because it's a very highly specialized area and because it's such a sensitive topic, I think it's really important to have a dedicated team. I think everyone needs to be trained on it.
Just like any other population, we do have women's health and men's health specialists. So why couldn't or shouldn't we have a gender health clinic, that has people who really are much more knowledgeable and comfortable and confident, and they make it a large part of their practice for a reason.
Right.
I'm definitely going to, and I'm speaking as a woman here, I'm definitely going to go to a woman for my care. Mm-hmm. Always have, and will always prefer that. That will always be my choice. So as an individual, I like to see myself reflected in the person who's delivering the care. And I can definitely understand why others would want that as well.
So you've touched on another topic, which is something that you may do to help the LGBTQ patient population you're working with. Gradually, health systems and health plans are identifying providers on a voluntary self-identified basis if they're a member of the LGBTQ community.
That's fantastic. I've seen that in mental health, not a lot on the medical side.
Yep. It's just happening. Mm-hmm. That's a good first step. Mm-hmm. But I was presenting at I actually did an open benefit enrollment session, which typically are kind of boring, frankly. We did one very focused specifically on the needs of the LGBTQ employees. Mm-hmm. They asked for that from their benefits leaders. And I came in and it was interesting. We sent okay, here are the questions we have that are specific to the population, and the benefit vendors, the medical plan and so forth came back and they had their generic deck. And I went, wait a minute, you didn't answer any of our questions. And so they're like, oh, I said, yeah, we want this specifically focused on these questions. Right. And so at that, we had a medical director from a health plan who stood up and he said, I'm an openly gay man, so I'm a member of the LGBTQ community, but I am not qualified to treat a transgender patient. That's a very specialized skill. Yep. So I would just suggest to you, that's phase one, identifying is someone a member of the LGBTQ community. The next step is identifying cultural competency. And this is true again for any underserved population. And I've identified 3 levels of cultural competency. One is self-attestation. So there are organizations out there, the Gay Medical Lesbian Association, OutCare, and so forth, that a provider can go in, medical or behavioral, whatever, can go in and basically do a self-attestation saying, yes, I agree to treat patients respectfully and so forth. So that's out there. There's also specific ones for behavioral health. Inclusive therapist is one that comes to mind. Okay. The next level, and again, true not just for LGBTQ, but any underserved population, is then a training and testing around cultural competency. So not just this, yes, I'm competent, but actually providing a training and then they typically pass a test. And there are some organizations, emerging organizations that do that as well. And then the next level, which I have not seen yet, which is then looking at the data to find out, are there outcomes better? And I don't mean just clinical outcomes, that's important, preventive screenings, chronic care screenings, but also the member experience with that provider. And so that's the next level. And so starting with self-attestation, going to the cultural competency training and testing, and then ultimately looking at outcomes from a variety of perspectives, physical, behavioral, and most importantly to me, member experience.
Absolutely, absolutely. I really love that directional progression, and I can definitely see opportunities abound for us to go in that direction. I think, for us to really get to the point where, the Institute of Medicine's quality chasm report and, the 2011 report and the 2015, policy reports, for us to really achieve and accomplish and get to that point where we're not, sort of like teetering on the line of going back and forth based on political climate in the United States. If we can just get a little bit more solidly in that direction of equity for all, I think a lot of it has to do with training. And I think it also has to do with, identifying specialty care and attaching it to, are the outcomes better? And then making, not just the business case, but the health case,
right,
population to be served where their health can be optimized.
Yep.
So.
Yeah, and of course, tied to that, which I skipped over when I talk about policy, is collecting sexual orientation and gender identity data.
Yeah, that's a huge area. We just have not done a very good job collecting enough data, and of course, to tie that back into the political climate, and to go back to what you mentioned, some people aren't out because they don't feel safe, and so until we have a truly safe environment, not just politically, but societally and environmentally, I think we're going to continue to just, there's a reason that the census doesn't represent all of us.
That's right. That's right. There is guidance from both the Human Rights Campaign and the Fenway Institute in Boston on collecting soji data. HRC's more general. Fenway Institute provides guidance for healthcare providers. So just if you're interested, I would make that recommendation. But any of the demographic information, race, ethnicity, gender, disability status, veteran status, soji data, all of that's important. Again, reiterating the intersectionality component of who we are. But I would say some employers are starting to collect soji data. The Boeing company just a couple of months ago, for example, started collecting that on a voluntary self-identified basis, just like we collect race and ethnicity data when someone joins, and gender when they join an organization. So we'll see what happens. I think it's a year or two out before we see it applied to healthcare from a health plan perspective. But I know health systems are collecting that data, and that needs to be taught about how you ask those questions.
I was just going to say, because that, to go back to are we accidentally trying to out, individuals or force them, to disclose data that they don't feel safe disclosing, and we don't want to go. So. And
if they do disclose it, making sure you find out if they want you to redisclose that to anybody.
Absolutely.
Because there could be family members that if they found out, there could be repercussions to that individual. So you need to be really clear about if and when and how to use that data, if they're willing to share that data with you. And somebody say, sure, I don't care, it's fine, or yeah, no, I want it to stay between you and me and the EHR.
Right. So I have one more question, and then we're kind of getting close to our time here. But my question is on, are there any legal challenges or maybe hospital or organizational policy challenges in allowing individuals to choose the family that they want to be at bedside if they have a surgery or if they're in recovery? What's that landscape look like? And for organizations that are wanting to be more affirming, is it an organizational policy or a law they need to be aware of so that they can make sure, from a compliance perspective, that they're doing everything they can to support the individual?
So what I would recommend, not to end this on a sad note, but to get will, advance directive, healthcare power of attorney, and all that in place, so that's very clear in terms of your wishes.
Okay. I think that's for all of us, Michael. I really do. I truly believe in and have been advocating for that for a lot of my patients for years. So.
Yep. I think on the flip side, Dr. English, you could cause health and safety issues if you allow family of origin in.
Absolutely.
When there are issues, and I will also tell you, the so-called conversion therapy where people are trying to convert in terms of gender identity or sexual orientation, it happens with adult children too, by the way.
Yeah.
So there's many states and jurisdictions that prohibit it for minors, but I will tell you, in my term LGBTQ commission in the city of Seattle, we had a complaint from an adult child who was essentially kidnapped and forced into a conversion therapy camp. It's still happening.
Yeah, it absolutely is. And sadly, as a behavioral health, we're a higher education, university, and from time to time we get questions about, conversion therapy from parents of, individuals who are looking for that kind of therapy. We have gotten a couple of those inquiries in the last 6 years, but when we do get them, it's always a surprise because it's coming from parents who have adult children, and they're looking for those resources to force people into those kinds of buckets. So yeah, it's still happening.
And another thing to think about too is if someone's coming in and, for example, getting psychotherapy and they had a bad experience before, I would just suggest to those of you that are practicing clinicians that you might want to probe a little bit, because what may have happened is conversion therapy, but it wasn't called that.
Mm-hmm.
And
that's come up for me with some of my patients. I definitely when I've asked, I always ask, have you ever had therapy before? And what was the experience like? Did anything that you did before work or turn you off from therapy? And every great once in a while, I do get somebody who says, yeah, it was very religiously involved and directed, and it was directed at conversion, really.
Right. And so there's trauma from that, right?
Absolutely. Yeah.
So, great. Well, this has been a lively conversation. I really appreciate it.
Oh my gosh, I really appreciate your, you are a super busy man. So, those of you who are listening and or watching, I just want you to know and appreciate and be grateful that Michael took this time for us. I really am grateful to you. So. Oh,
thanks. Thanks for inviting me to come and share. That's great.
Thank you so much. And like I said, for those of you listening, I'll link the resources that Michael was sharing, the slides, and an article that he recently published in this area. So thanks for joining us.
Thanks. Bye.